is, it's recording now. My favorite one here is, and now that you don't have to be perfect, you can be good. Because what we're really working on here is, not striving for bodily change or manipulation. We're working more on just accepting yourself. So what we're going to learn here today is who the dietitian works with. Here we do work in an interdisciplinary team, and depending on the setting that you're in and the acuity, there will be a little bit of a different team that you'll see. We're also going to speak about the dietitian's scope of practice and our expertise, going through nutritional rehabilitation, which is probably what most of us are thinking when we think about the dietitian's work here in this setting, as well as medical concerns. We'll go through exposures around foods and around some other areas that we'll talk about as well, and really doing some nutritional psychoeducation around food beliefs and what is actually true and what might be a little bit disordered. And then moving through body image as well as exercise and movement. We will then talk about when to defer to another provider and remove yourself from that situation, just really being aware of what is within your scope of practice and what may be in someone else's area or what you need to work together on. We also want to make sure that we're providing respectful and factual care and that we are truly giving the patient information that is valid and not also giving them anything that won't be true that their eating disorder might take and run with. So working as a dietitian in the field, we're also going to go through day-to-day practices and just what you need to know if you have interest in working in eating disorders. If you already do work in this area, you'll probably be a little bit more familiar with all of the things that we really do go through here in this setting. So first off, who do we work with? I would say the main person we work with is actually one of the lower ones down the list, of course, the patient. They're going to be the primary person that we're working with because it's really their care and we are just a part of it for them. So they should be dictating, what route we're taking or what we need to work on first because they can tell what's top of mind and what they're really struggling with in that moment. From there, then we move in with the outpatient team. We usually try to meet with them even before the patient admits to find out what they've already been working on, what their goals were with this patient so that we can continue that and not go over things they've already done or things that they really excelled at. We want to know what areas were hiccups for them so that we can focus on that and find out what we need to keep moving forward on or what we really need to push on. Also with that, the outpatient treatment team working as a dietitian is going to be able to tell you about their meals, about their intake, about their weight goals that they did set with the patient, and where we need to tailor their care from there. Then you're looking at working as a team in-house, which would involve the therapist, family therapist, psychiatrist, and medical provider as well. This could involve the patient's family as needed as well, and you'd work with the family therapist on that. So when working with the therapist, we're really looking at, what are you working on in your sessions? Are you processing a lot? And do we need to take a little bit slower on the food, or should I not challenge them this week because of the things that they're really getting into? Is it a trauma response? Is there something going on? So they can help tailor your sessions a little too and how deep you want to go. The family therapist can help tie in if, let's say, their home environment can be a little stressful or the holidays are coming up, just like we have Christmas coming up right now. Lots of family visiting. What's conversation like at the table? Should they have the dietitian come in and really talk about what's helpful to speak about in those moments? Or what would actually be a helpful meal plan? Should they serve up the plate for the patient? Should they let them just do their own thing? How can they support them in those moments? Then, of course, the psychiatrist working on any medication changes. Normally when we'll see like dry mouth, changes in appetite, some of those things going on, there was a recent change in medication and we can actually see how that's interacting. And then, of course, we have the medical provider seeing a lot of, GI issues coming in the door, things that can be helpful for them to work with the medical provider on, as well as monitoring lab values, making sure everything is stable and that they're doing okay, and that we can change things as needed and monitor the patient day to day. So what is within the scope of practice for a dietitian? Well, clearly nutritional rehabilitation. So just like in any practice with a dietitian, we need to also focus on any comorbidities that this patient has. So first and foremost, we really do focus on the eating disorder, whether that's anorexia, bulimia, BED, OSFED, ARFID, any of these things that we might be seeing. Aside from that, we still need to take into account anything else that's going on with this patient. So we do see a lot of patients that come in post-bariatric surgery. Let's say this was a binge eating disorder patient, and they were getting the bariatric surgery because they thought that that would actually end the binging because they would no longer have that option. However, what we see is the binging does still occur maybe a month or two out from the surgery, and then there's a ton of dumping. A lot of GI discomfort. So we have to take that into account, maybe plan some more smaller meals throughout the day, getting in more frequent nourishment, move the fluids outside of the meals, and be conscientious of that. Same thing with diabetes, looking at type 1, type 2, is there insulin misuse purposefully so that they're not actually getting that nutrition? Or is it more just management around blood sugars? Of course, getting, it used to be a CDE, but now a CDCES, on board, or getting your medical team on board too, if you're needing to tailor that. GERD and reflux, of course, you're going to see a ton of that with your patients that struggle with purging. So until we can really get a handle on that, we're going to have a lot of reflux for the most part. And even once we do get a handle on that, it might persist if there's been a longevity of purging in their life. Also focusing, of course, on hypothyroidism, as well as, heart disease or any cardiac issues, as well as really any other medical condition that's going on with that patient. From there, we're looking at electrolytes. Of course, the main thing we're looking at is refeeding. We want to make sure all of our patients are safe and do a thorough workup before they come in to make sure that they should be in a safe place. However, then monitoring as we're increasing that nutrition to make sure that their body is taking that in appropriately and we're not shifting into refeeding. So with that, we also, on top of the magnesium, phosphorus, potassium, with refeeding, we're looking at sodium. This is going to tell us if they're water loading, maybe taking in a large amount of fluids before meals to eat less. Maybe they're water restricting because that is coming in with that restrictive mindset and they're trying not to put extra weight on their body or take in anything extra. We're also looking at glucose, of course, to make sure that when we're renourishing, the patient is taking that in adequately. Maybe they're moving into hypermetabolism and we need to increase that nutrition and get in more glucose actually. We'll look at bicarbonate to see also if a patient is saying that they're not purging, but we're seeing that, the bicarb is high. They might be going into metabolic alkalosis and they might truly be purging. And this could be a telltale sign of that. Also, if this is reading low, they could be in metabolic acidosis. So we do want to monitor that as well. Then looking at the LFTs or the liver function tests to see most of these will rise with our patients that have been severely restricting and are malnourished because their body is having to then break down protein and fat and metabolize that through the liver to use that as an energy source. However, when we actually can then reintroduce nourishment to their body, their liver is having a hard time. Then it's saying, oh my gosh, I finally have this energy source. I finally have this glucose, and their LFTs will rise. Normally, we can see a rise also with refeeding, but more long-term, we can see some, liver dysfunction with this if they were in severe restriction. This will normally normalize after a bit of time. It can take weeks to months, and you might have to actually tailor and lower the carbohydrates slightly depending on what you're seeing with this. But that's normally in a more acute setting or patients that come in really severe restriction. And then, of course, the creatinine and the BUN. When we're seeing these change, we're also looking at hydration and malnutrition. So more within our scope of practice. So a lot of what we do is nutritional psychoeducation. It's really trying to set the record straight. So dispelling myths about foods, and this is a big piece of what we do. Working through factual information with the patient and letting them actually bring up what they believe about food, what they've heard growing up, and what they believe to be true, so that we can talk about, okay, this is what the science shows, and I wonder where this information came from, and what do we think about that? Can you hear the truth behind this, or what is the eating disorder still saying? Then looking at fear foods, finding out from this patient why they're so uncomfortable. Let's say we have an ARFID patient. It could be more of an experience for them because maybe this is a patient that actually, vomited or choked on something when they were young, and now they have a really difficult time reintroducing foods past that point in their life. So they only eat foods that were comfortable before that time, and they tend to be more childlike foods, mac and cheese or chicken nuggets. This could be about the calories or the certain macronutrient. We all know carbs get picked on quite a bit, or just sweets, because they're more calorie dense, fats as well. So finding out what it is that creates the fear for them, so that then we can focus on which foods we need to look at. And then working to integrate these foods gradually and broaden intake, so that we're not just limiting intake to what they're always comfortable with. We'll also look at fad diets. We run a group every 12 weeks on fad diets and just go through what they all promise and then what they actually deliver. And the patients can talk about, their experiences with them, or what has happened within family systems, with friends, what they hear, day to day, and we can talk through that. We'll also look at supplements and looking at what can be achieved through balanced intake and what are they taking in. This could be through Boost, Ensure, something of that sort. It could also be looking at different vitamins, minerals, or just like holistic supplements, finding out, were these recommended? Did they just start to take them? And why did they do so? We can also do grocery shopping and actually go to the store with patients so that they can get a little bit more comfortable with picking out the things they need, not looking as much at labels. And when this has become less of an option with COVID, we can still do things like click list or help the patients actually go through and plan out rounded meals so that they can get all the things that they're needing. We also do work on meal planning, making sure that they have a solid idea of everything they'll need. And then cooking. We have an in-house chef that can work with the patients one-on-one and work on foods that are specifically difficult for them, or things that they've never really learned to cook growing up that would be helpful. And then, of course, we have orthorexia, or the clean eating movement, which when you actually look up the definition of clean eating, nothing truly appears. But there is that consistent theme when you talk about clean eating with people. It's normally, like unprocessed whole grains, and looking at how that affects their day-to-day life. Do they spend all day cooking? When being around food can be difficult for these people, then looking at this and spending that much time in the kitchen can make it even more daunting. So how does that really fit into their recovery? So then we look at exposure therapy, food exposure specifically in this instance. So this is a form of cognitive behavioral therapy. And we're looking at exposure to foods that the patient finds uncomfortable, but we do this in a safe place, in a controlled environment. We also do this with the patient so that they can work through this experience and see that they can eat these foods and they don't need to be things that are commonly feared or avoided. And then we repeat this exposure until the food becomes a little bit more comfortable. And as one becomes less daunting, we can move to the next, until we really get to those foods that are very, very challenging for the patient and they may have not eaten it in 15 years. The thought around this too is that the repetition of doing this leads to decreased fear, anxiety, and avoidance around that food or other foods in that genre. And then doing this with them so that they can see that this is normal to just have a burger and fries and to sit down and have that happen. And as they become more comfortable with this, we can move into more unpredictable scenarios, or going out to eat, doing a restaurant outing. Maybe they have something coming up with a friend and they do hope to actually learn how to go to a restaurant and just eat out and order something. So we model that behavior and we go out with them and try that. So things that you might see at these meals, that when you're one-on-one, you can really work on redirecting in the moment and finding what's helpful for them. So there could be separating the meal out. There could be tearing, like if you get a croissant or something small, just like tearing it into little pieces. Picking at the food, like picking out one little thing at a time. Chewing and spitting the food out so they're not actually swallowing. Cutting the food into very small pieces. They could order the food, so eat all of one thing before moving to the next. Weighing or measuring foods, which is a good reason that we really work on visual portioning and taking cues in that way instead of using measuring cups or scales. They could eat very slow, eat very fast, or have both happen at the same meal. They might start very slow and try to delay so that they won't be able to finish. And then at the end of the meal, consume everything in the last 5 minutes so they can't feel that fullness building and then be done with the meal. Using specific plates or utensils. We have a patient right now that uses chopsticks for every meal because that would slow the pace that they were able to eat. Excessive chewing, so they slow the meal. Avoiding touching foods. We have had patients that find that they actually believe the calories will absorb in through their skin if they're touching it. Over or under consumption of water. Excess condiment use, so they're only tasting the condiment, they're not actually tasting the food, they can't enjoy it. Or overheating foods, so they might burn the taste buds and then they don't have to taste the food. We've even had patients try to heat up salads or things like that just so that they're not enjoyable, because a lot of times there's a lot of guilt around enjoying a food. So another area that we focus on that a lot of times, therapists are really working on this area, but this is an area for us to explore too as dietitians, is body image. So asking the patient, how do you see yourself? Because this can help form how we work with them on this. A lot of times there's a huge disconnect with how they actually perceive their body and how they see themselves and how they actually present. And how do you feel in your body? Are you comfortable? Is it so uncomfortable? What's uncomfortable? What makes you feel that way? When did this start? What do you believe about your appearance? Everybody has something they focus on. So it's really important to know what they believe and what that area is, because as there's renourishment, as we get these behaviors under control, that's going to be the area that crops up. And that's going to be what they end up focusing on. So if we can get a little bit ahead of that, that's going to help our patient. And have you ever felt comfortable in your body? And if so, when was that? So that we can really take a look back and see what's changed since then. Distorted perception versus clear perception of your body. And sometimes they do have a clear perception of their body, but it's usually not a very clear perception. There's usually at least some distorted areas or just areas of such hyper focus that they become distorted. And then family messages growing up. This could also be from friends, just other people that they grew up around. And, were there diets in the home? Was there always a message around needing to exercise? Were there always like protein shakes at the house instead of meals? Or, was dessert deserved? Was it something that they could just have freely? And what really interplayed with this? And then societal messaging or pressures around food choices, body shape, or weight, which, as we all know, are just rampant in our society. So a lot of times what we'll explore is, what is the patient's personal concept of beauty? So we have our traditional ideals that I've listed up here, where males are normally looked at as strong, muscular, lean, masculine, assertive, tall, tall, dark, and handsome, that kind of thinking. Whereas females tend to be thin, large, breasts, toned. They care about how they look. They do their makeup. Maybe they wear heels, things like that. So finding out from the patient, is this their idea of beauty, or what is their true idea of beauty? Does it fit this concept? And then working with them on this, also emphasizing the function and the strength of their body over its appearance or their form. Look at the things that it actually does for them. Look at how resilient it's been over these years, going through all these behaviors, instead of looking at a specific area on their body and how it's changed. And then the biggest piece of work we do from there is working on body neutrality. So a lot of these patients come in and they do not like their body at all. They're in body avoidance, or they don't like their body. So if we can work towards neutrality, we can at least get to a place where they're not hating their body. They might not be loving their body, but they can accept their body and acknowledge that it does a lot for them. From there, we do try to work on positivity, but that's normally long-term outpatient work if they really do struggle with body image, because as we all know, body image is difficult just in the general population, nonetheless, if you have an eating disorder. So focusing on body respect, because we have to respect our body and all that it's done to be able to be neutral with it or show it appreciation. We can also do a body image timeline, and we can look at influential events and experiences that they have gone through and how their body is perceived. There could be something influential that happened, in adolescence or in childhood, and this can help us see what happened at that time and how it influenced their perception of their body. Also going through, body checking and avoidance. Some patients hyper check their body, look in every reflective surface, have to pinch, have to measure every day, have to weigh. And then we have patients that actually deal with it in the opposite sense by avoiding their body, covering everything in large clothing, and not wanting to even connect with their body at all. So we see where they're falling on the spectrum and try to put some challenges in there for them. We also try to work on affirmations and focusing on the positives within the body instead of, numbers on a scale, knowing that their actions define their success. And again, this might not be completely a positive, it might be a neutral statement, but it won't be a negative statement. We're not looking at what's wrong with the body. And then here, just like with the food exposures, we can also work on exposures with body image, where maybe they remove old clothing that doesn't fit anymore, that they keep putting on to body check in or to feel uncomfortable in as like guilt. We can also work on wearing clothing that doesn't hide their body. Maybe there's a challenge to, wear a normal just t-shirt one day instead of having to wear a large hoodie. So movement. This clearly connects with nutrition and something that dietitians really have to be in touch with. So first and foremost, the patient has to be medically stable. If they're not stable, they should not be engaging in movement, or they're going to be creating more harm for their body. And then ensuring their nutrition needs are being met consistently, not just, when we start movement, but if they really get into it and then they're backsliding on their completion, we need to stop. We need to make sure that their weight is not compromised by the introduction of activity if they are, working on weight restoration. So weight focus should not be the primary intent of that exercise for them. We need to refocus movement towards enjoyment instead of control over the body or weight loss. With this, we need to see an absence of disordered behaviors. We can't have, purging going on. We shouldn't have binging going on. We shouldn't have restriction going on, laxative, diuretic use. We need to not be engaging in these behaviors to be able to safely engage in movement. And then talking with the patient also about the value found in engaging in these types of movement. What is it that, running does for you? How does it make you feel? Can you tell when it's disordered and when it's authentic? And are there other forms of movement that you really enjoy or that you haven't even tried that might actually be kind of valuable for you? And then looking at the frequency, duration, and intensity of that movement that they're engaging in, so that we can really start slow and build from there and see how they're doing with that. We might even be there for oversight or support if needed. Maybe for their first run, you go with them. You don't have to run by any means, but you're there to check in and say, okay, we know that this was something that you really struggled with before. How did it go this time? And what were those thoughts that came up so we can process that? And then allowing for variation, which is something when someone struggles with overexercise and movement coming in, this is usually the most difficult piece, is that variation, actually being able to wake up and say, I'm tired, I'm going to hit the snooze button. I don't think I'm going to go to the gym today. And their eyes just get wide, like, what are you talking about? But you should be able to wake up and say, I'm not feeling well, I don't want to, or it's not the day, maybe I'll go later. And being able to find enjoyable movement, something that really sounds good that day, instead of just engaging in the thing you always do. And not going into those rigid patterns, like having to be on an elliptical for 30 minutes flat. We need to branch out and find things that are actually enjoyable to be able to get a healthier relationship with movement again. So something that we've created here too is a movement check-in sheet. So we'll use this with our patients that are starting to get back into movement, that have had a history of disordered, thoughts around movement or behaviors with it. So first we'll write out the type and the duration of the movement that they're engaging in. We'll look at their energy level before they're going in to move, and then after, as well as their stress and how they're feeling. So they can automatically go through here too and see if their stress is at a 10, maybe they're using this as a coping skill. And maybe that's not a healthy coping skill for them. Maybe it is. How are they feeling? Are they feeling sad going into this? Are they feeling really happy? Are they excited? What's the function of the movement for them? Why are they engaging in this right now? And then fuel. Have they actually fed themselves appropriately to be able to engage in this movement? Because that's what we do, try to train our patients, or re-teach our patients. And here is that, we fuel and then you can move your body. We don't move our body to earn the fuel. And then fun. What's actually fun about this type of movement? If there's nothing fun about it, then why are we engaging in it? So a couple good questions to ask patients too is, if exercise had no capacity to change your body, what would you keep doing? What might you try? And what would you altogether just stop doing? What is not enjoyable? What is your relationship with movement actually like? And what are your current exercise habits and how do they serve you? Do they feel healthy? Do they feel unhealthy? Are they actually, injuring you? And then knowing, of course, when to defer to another provider. So, working with a psychiatrist or a medical team on blood sugar management, changes in medication affecting intake, if we notice things like that, the hypothyroidism, and also post-surgical nutrition. If a patient needed oral surgery, we need to collaborate with them on what they're needing nutrition-wise, like soft foods, or how many days worth of that. What do we need to do there? Because we are the experts on what we then provide, within that macronutrient, micronutrient wise. But we do need to get their recommendations on first steps with that. Working with a therapist on trauma foods, maybe they presented it to us as a fear food, and then we find out later that it was actually linked to a traumatic event, and that's not a food that's appropriate for us to reintroduce solely as a dietitian, because there will be trauma that comes with this. I know we had a patient that, had traumatic events around fried foods. This trauma always happened when they were in a car getting fast food. And so even just the smell of fried foods or fast foods were so difficult for them. So it took us a couple months to even work on having a fried food in the room and just having that smell be present. And we did those with the therapist present as well, so that they could really talk through what was coming up. We also have to work with the family therapist on the conversations at meals with loved ones, roommates, significant others, supports, really anybody in their life they need to bring in. Ways to approach eating at home, also expectations, boundaries. It's a lot easier for someone to say, it's helpful when you say this at a meal, it's not helpful when you say this before the meal, as opposed to in the middle of it, which is when a lot of people tend to bring this up, like, oh, is that nice when I just said that right this second? They're just in the middle of the meal. So working with them on setting that expectation or knowing guidelines beforehand. And then also working with physical, occupational, or speech therapy as needed. We do not have them in-house here. I think it's wonderful when people do, but we will, refer out if we're needing a little bit more specialty. Maybe you notice a patient is chewing in the front of their mouth and isn't moving the food back to actually be swallowed. We might need to get a speech therapist in there just to tell us, like what's going on. Also reintroducing movement and getting clearance. You might need a physical or occupational therapist to help if someone's very malnourished or has had difficulty with an injury. So what dietitians do day to day? So as we all know, we have the nutrition assessment, clearly going through medical history, weight history, treatment history, health complications, of course, GI health. There is normally always something with GI health here, whether that's constipation, diarrhea, cramping, bloating, something going on. Going through different supplements, herbal supplements, vitamins, minerals, anything they're taking. Looking at allergies and intolerances, which is a really difficult one, as a big piece of the eating disorder can be removing foods from the diet to limit options. And with this, we do ask for testing to come in that is normally IgE, so that we can verify that, or a medically controlled test where they do ingest the food with a physician. We do come in with some intolerances, of course, that you can't really test for, and you really have to monitor that patient, how the ingestion of that food is going, and try to be as safe as you can about that, and choose your times wisely, because we have to remember that first and foremost, we're here to make sure the patient is re-nourishing and taking in enough. And usually we'll start there and then reintroduce these foods. However, if they really have no basis or no standing for claiming some of these allergies, we will just go ahead and reintroduce. And most of the time they're able to ingest these foods, but had cut them out a long time ago and just hadn't had them. Looking at medications, of course, lab values like we spoke about, behaviors and frequency, going through a food recall, seeing if that's changed even in the last week before admission, or what they are taking in, as well as fluids and caffeine. And then observation, of course, what you're seeing in that office is probably your best inclination, honestly, as to what is going on with that patient. If they're avoiding not being honest in answers. That's going to give you an inkling there. And then setting goals with the patient or letting them set their own. Maybe they came in and they were like, you know, what I really want to do by the end of this is I just want to be able to like go out to eat with my, you know, boyfriend, and I just want that to be okay. So we'll work on that. So things you might see, very, very common, gastroparesis, so slowed GI emptying. So we can use, you know, some medications, maybe like Reglan, to help with that gastric emptying. It's especially at first, as the stomach is not normally getting that amount of nutrition consistently and needs some time to catch up. So we're going to provide smaller, frequent calorie-dense meals that are low in fiber, doing liquid a little bit more between meals, still needing that at meals just to help move it through a little bit. And normally that will normalize within a week to a month or so, but it depends on the level of restriction that they've really been undergoing and for how long. We'll also see a lot of constipation, you know, like GI issues, loss of menses. We'll see lanugo, or, you know, fine, soft hair just growing all over the body to try to keep them warm if they've been in a restrictive, undernourished state. Seeing poor dentition if there's been a lot of purging or sensitive teeth. They might also have severe reflux or like burning in the esophagus commonly. We'll see dehydration, cardiac abnormalities from abnormal lab values and electrolytes. We'll see swelling of the salivary glands if someone's been purging for a large period of time and then stops. They'll actually swell because the body is used to, you know, ridding themselves of that, and all of a sudden it can get very painful and they'll almost look like chipmunk cheeks. Although this can be harder to see now that COVID is still a thing and we have masks on, it kind of covers that. We'll see lethargy, dizziness, fainting, as well as, of course, irritable mood. So what we'll work on day to day is reassessing nutritional status, and that also goes with physical as well as mental health. Because the patients, you know, like as they're going through this, it's not easy to push up against the eating disorder. And we have to check in on how they're handling this and how they're truly doing. Looking at their meal completion, what barriers they're facing. Is there anything that we can help them work through and come up with some skills around? Their behaviors and their frequency, are they increasing? Are they decreasing? Have they stayed the same? And then tailoring the session from there. What are they struggling with in this moment? Has portioning been really, really hard? Do we need to talk about hunger and fullness? Are they starting to get their hunger fullness cues back? Because those normally do get lost as there has been, you know, inconsistent nutrition. We're not getting that ghrelin and leptin, you know, response that we used to, and it can take a while to get those back. And then when they do come back, they're like off, and we need to fine tune them in. Is it, you know, fact checking around some fad diets or around some things that they heard? Or do we need to work on body image or intuitive eating? And then, of course, goal setting, even week to week. If you have someone that does really well with setting a goal and meeting that goal, meeting them where they're at with that and having some challenges for them every week. So the nutritional psychoeducation. So normally we do run nutrition groups every week that go through, you know, different, just general broad nutrition information, setting the facts straight on macronutrients with your carbs, protein, fat. We're getting in hydration, micronutrients, digestion, metabolism, going through portioning foods, movement, and making sure that we're always providing current information and updating these consistently. And then challenging beliefs held around nutrition and these macronutrients, how your body uses them, how much is needed. Because it goes without saying, most people come in here thinking that you should eat all the protein in the land, carbs should be the lowest intake of anything. And it's always mind blowing when I'm talking about, you know, at least half of the diet being from carbohydrates. And it's like, why, how, you know, I can't believe that. So it's really talking through that with everybody in a group setting as well, to show that they're not the only one that has these beliefs. However, together we can all learn why it's so important. With this, it's important to watch body language, because you will get some strong reactions when you're going through sensitive subjects like this. And sometimes answering questions after the group, if it's a specific patient really struggling with something individually, and talking through that with that person. Something that we can work on day to day is mindful eating. So this is more about being present during the meal, just asking, you know, like, am I hungry? Am I thirsty? Trying to be in tune with the body, trying to be present, being non-judgmental throughout the meal. letting yourself know that, this is what I'm eating for lunch. This actually sounded good. I'm going to try to just eat this and be present with the meal, acknowledge the aroma, the texture, the taste, see what comes up for you in that moment, and just be present with your meal. We don't have to be, like watching TV during this. We don't have to be driving and eating as we're going. A big tenet of this is just being really present during that meal and taking the time needed. From there, we can work into intuitive eating. This does tend to be an area that we focus more on in outpatient care, because normally coming into a PHP level of care, we're not able to really get our hunger and fullness cues tuned in enough to eat intuitively, truly. There can be a little bit of dabbling or getting into it, looking at the tenets of it. However, it's pretty hard to be at this level of care. So of course with this, we need to reject the diet mentality and be able to honor our hunger and feed ourselves when we are feeling hungry. Making peace with food and making authentic choices around that as to what sounds good in that moment and how we know that'll make us feel later through the day, what will serve us best in that moment. Challenging the food police and not letting them make those calls in those moments. Discovering the satisfaction and allowing, that feeling of fullness to actually settle in, and knowing, okay, this is all right. And I'm feeling pleasantly full, or I'm feeling a little overly full, and just being able to sit with that. And with that, coping with your emotions with kindness, not needing to fall back on food, when there are heightened emotions, and respecting your body, movement, feeling the difference, not exercising in a, rigid regimen, and honoring your health with gentle nutrition and being gentle with yourself, because of course that's quite important. Working on hunger and fullness cues, as we talked about, these can get really misconstrued. And so as we start to get these back, working on, okay, maybe when I'm starting to feel hunger and fullness cues again, I'm always just feeling ravenous before a meal, and afterwards I'm always feeling like bloated or nauseous. And there's not really an in between. We're on either end of the spectrum. And as we work on this a little bit more, it should come back to maybe I'm feeling hungry or neutral before a meal. And then maybe afterwards I'm just feeling full, or maybe just satisfied. And we can start to fine tune this a little bit more and see that when we get that consistent nutrition, we don't have to go to starving before we eat. And we don't have to eat until we're feeling nauseated. We can eat when we're feeling hungry or neutral, and that can be fine. That's actually a good place to feed our body and then be able to get through the day feeling nourished and good. So then we also have emotional hunger and fullness, which is huge, right? Because with emotional hunger, this can be very demanding, and it can be something where that hunger amounts very quickly. Whereas normal hunger builds gradually and we can feel it coming. These patients might not know that feeling and just feel it come on immediately and feel that they need something and they need it now. Or that they're so full because they're just emotionally stuffed that nothing else, they cannot eat even though they haven't eaten all day. They feel so emotionally full. So it's really important to differentiate these things. With emotional hunger as well, it's usually a specific food craving, like, oh, I need that cinnamon roll and I need it now. Or, oh, a burrito would only be the thing that could satisfy this craving right now. And it demands immediate attention. We need to feed that right now. And the thoughts of the food really aren't dissipating with this. It's that consistent thought of like, wow, I really need that. I really need that. And this leads us to a place of being more likely to eat past fullness that could result in binge behaviors, often linked to feelings of guilt or shame, and then feeling emotionally unsettled with this as well. So before and after the meals, we are looking at physical hunger as well as emotional hunger, because maybe they can differentiate that and say, emotionally, I've had a really hard day. I'm feeling really sad. I'm feeling really drained, and I'm feeling, full. I'm feeling full emotionally. But when they check in physically, they're like, I can tell I haven't eaten in about 4 hours. I am feeling actually a little, lethargic, and I think I could actually eat physically. So of course, we do work under a HAES model. So including weight inclusivity, accepting and respecting the diversity of different body shapes and sizes. We're looking at health enhancement and improving access to information and health services, providing respectful care, and making sure we're eating for well-being and promoting flexible, individualized eating. And this is what we're working on, through this process, is we start with the meal plan and making sure that we are getting that consistency. And then as everybody's able to do that, we find those patients that really would like to eat intuitively and feel that they are actually getting accurate hunger and fullness cues that can start to work on that hunger and satiety and truly be able to follow that. Many patients cannot and actually really struggle without a meal plan. So it's working with that patient on a one-on-one basis. And then life enhancing movement, finding things that are actually enjoyable and that make their day better, not things that feel like they have to be done. Also making sure that we're providing inclusive care. Facilities must be accessible to everybody. So with that, we have to look at entryways, furniture, railings, different scales, restrooms, entryway chairs, just making sure that everything is appropriate so that people can, get through those facilities and utilize them appropriately. Make sure to always ask pronouns. That's extremely important. We don't want to call anybody by the wrong pronoun. We do have a diversity, equity, and inclusion committee as well. So here we do try to make sure that we are taking all of this into consideration and hearing people, because we can always improve, right? I'm sure every facility can. So it's important to hear that feedback. And making sure not to stigmatize weight, not using weight size or BMI as a marker for health. As you know, with insurance companies, this is extremely difficult because this is one of the main things they focus on. However, we do try to re-steer those conversations as able and provide education so that we're not using this as a main marker for health. Definitely, educating patients on this when they're asking, what's my weight doing? Talking about, how weight does not define health right now. And we're really just working on making sure that their nourishment is appropriately and that they're feeling better in their body. I find this to be a really powerful quote, so I'm going to read this one. Weight stigma, a negative response to someone based on their weight, is the fourth most common form of social discrimination amongst adults, after age, race, and gender. It is the only form of discrimination still widely deemed to be socially acceptable. And that's so powerful. Why is this socially acceptable? Why are there still comments going on around people's weights? And why is that such common conversation? And this is something that we can all look at and say, okay, at least I'm not going to be a part of that conversation. And listening to the patient's presenting problem. A big part of what we hear is, going into the doctor's office and I came in with a problem and instead all they wanted to do was talk about my weight. So then they avoid, that practitioner's office. So making sure that we're getting them providers that are inclusive and don't make these comments or are HAES informed, which can be difficult to find. But on the HAES website, you can see a list of providers that are HAES informed. Of course, then day-to-day collaboration with the outpatient team prior to admission, upon admission, before discharge, throughout their care. Meeting with the current team, we do weekly staffings where we all do meet as a team to make sure that everybody's on the same page. And then, of course, community collaboration, using outpatient support groups, stepping patients up as they're needing higher levels of care, lower levels of care, and assisting them with getting that care. These are some instances where you might need to refer to a higher level of care if they're not eating appropriately, if they're using laxatives, diuretics, continuing to purge. This could be through exercise as well, or binging outside of supervised hours. If they're unable to gain weight, especially if they are following the meal plan, they might need enteral nutrition. They might need something to help them if they just are having a difficulty, meeting their needs. Avoiding meals, needing more supervision, medical complications that they end up going to the hospital quite a bit, or loss of progress when they're stepping down or staying at this level, as well as need for, enteral or parenteral nutrition. So the different levels of care, we have outpatient, which is the lowest, and then we have intensive outpatient, which will be like a couple days a week for a few hours, usually over at least one meal. We have your partial hospitalization or day treatment, which is what we are here at the Denver location, as well as at our Kansas City location. We are there, I believe Kansas City is 6 days a week, we are 7 days a week, and for most of those meals. There's residential treatment centers where the patients do actually stay there, and then inpatient hospitalization when they are extremely malnourished. And just ensure you're working with the full team. So here are all of our different locations and some of the different programs that we do offer. We do have adolescent care in Kansas City and Colorado Springs as well, which is pretty exciting to be able to serve that population. And then we have our CAMSA empowerment-based treatment philosophy, which is built off connection, acceptance, mindfulness, sense of self and action. So our patients really work on these tenets when they're going through treatment to make sure that, when they're leaving, they have met all these goals and they feel like they are connected, that they have accepted, where they're at, and how to move forward in their weaknesses, being mindful and non-judgmental, and having that better sense of self so they can have that connection to themselves, and then be able to put this into action and show us through practice, being in program, that they can do this and take that out into the world with them. All right, and here are my sources. And then I think I'll kick it back to Lindsay to see about any questions.
All right, thank you, Alison. That was great. We do have some questions that came up in the chat or question and answer spot. So one of the first ones that came up are, how is this, which it was when the body image slide was up, how is this approached within the gender identity realm? Do you have anything to offer to that, Alison?
Absolutely. So that's one of the biggest realms actually where body image comes into play, because a lot of times, if someone is undergoing transition or, identifies as female or male, or, does not want to identify, a lot of times they still do have an idea of what they would like their body to look like. So it's then talking to that patient specifically about, well, what is your idea of the perfect body and what are you looking for? And a lot of times that can coincide as well with, like hormone replacement therapy and what they're desiring in that realm. That can interplay with movement, that can interplay with restriction. And a lot of times there can be a lot of feelings or emotions that come up with, getting menstruation back if this person does not identify as female. So it's really going through in body image, what do you perceive as the body that you identify with? And how does it feel to be in a body that doesn't, identify that way or doesn't present that way? And it might be as simple as, like having breasts and not wishing to have them. And it might be outside of the eating disorder of something they can truly manipulate with that amount of restriction. So it's a tender subject, but a lot of times those patients are very able to speak to how they feel because they're looking for an outlet to be able to tell someone about that.
All right, thank you for that, Alison. The next question that we had are, what are some red flags that point to a person needing more intense treatment versus just outpatient treatment?
Absolutely. So some red flags as opposed to outpatient treatment, especially, I guess I can probably go back to the higher level of care slide. So, if they are an outpatient and you're seeing significant weight declines, I know over COVID it was difficult as well because we had some patients that were only doing virtual visits. And then when they did come in to see their provider and we could see, weight changes, whether that be a significant gain or a significant loss, it was like, oh my, okay, so things have been a little bit more difficult for you here lately. Recovery Record, if anybody does use that app where you can log intake, you can also log like exercise compulsions, urges, behaviors, anything of that sort. So that can be a good notification if they choose to use it. Many patients don't. And also through that report, if intake just consistently keeps declining, or if binge behaviors continue to grow and maybe they're actually happening like twice a day instead of the once a week that they were occurring, that's a red flag to at least call in. And you can always call in for a free assessment to at least learn if that patient would benefit from a higher level of care. Even if the recommendation isn't, our facility, we can help steer and see like what would be most beneficial for that patient.
All right, the next question that I have is, I am a community dietitian who is interested in becoming an ED dietitian. What are the first steps in becoming an ED dietitian, and what experiences are you looking for when hiring RDs?
Well, that's exciting. We always love to have more ED informed RDs. Absolutely. So I love that you're interested. And, where I started a lot, in looking into eating disorders and these sort of things, was normally reading. I don't know if anybody's read Dr. Gadiani's Sick Enough. That's a great book. It really goes into the medical complications. And then, of course, you can always read Hayes as well as Intuitive Eating, just to get some insight into those. I actually just read a book. It was called Fullness, and it's amazing. It was someone's self-account of their eating disorder that struggled with binge eating. And that also just gave a lot of insight into that area. And from there, making connections with other RDs in your area that also specialize in eating disorders. Sometimes you might even be able to come into a facility, shadow a little bit if you have high interest. I know here in Denver, due to COVID, it actually did slow down, but there was like an eating disorder group of dietitians that would meet every so often and just be able to talk through some of these things. So if you could, find some group in your area that's also doing that, that could be really helpful.
And you kind of answered one of the next questions with what you just said,
Yeah.
Allison, with some of the recommendations for reading materials, but that was one of the questions. Do you have any recommendations for literature for RDs to learn more about eating disorders? Any other ones that you would offer?
Let me look at my book rack real quick. I mean, let's see. My favorite ones. I also really did, I don't know if anybody's seen this too. It's called the F-It diet. That one was really good. But other than that, I would say Hayes, Intuitive Eating, Sick Enough, and Fullness were some of my favorites, just personally.
Perfect. Another question that just got sent was, could the recommendation of iAdept be suggested for training?
Oh, absolutely. Definitely. That would be a great option. And they will send out like virtual webinars and things like that at times too, that you can just jump in on. And that's a great way to get in there. And I mean, then from there you can, go after your SEED certification, but that'd be a long time down the road if you truly do want to pursue eating disorders as a specialization.
Sure. Okay, I think we have time for maybe just a couple more. So the next one that I have says, I have heard about athletes dealing with eating disorders. Do you have any advice for working with this population of patients, especially with the movement piece?
Absolutely. So we actually do have an athlete program here as well. And in working with that, it is really difficult because most of the time we do ask our patients to take 2 weeks off from movement coming in, because most of the time they say it's not that disordered. This is for my sport. And then as they actually get some time off from it, they find themselves like really panicking and finding out that this was a much bigger piece of their life than they ever realized. So then we can actually work through that a little bit before they reintroduce it. And we can work on bringing that in more slowly as they're able. And a lot of people will find that maybe they restrict more if they're not able to engage in movement. And then, oh my gosh, this was compensation. This wasn't just about the movement. I was moving to compensate for my intake, when they never actually realized that before. So with athletes as well, it's important to work with, if they are, going through a school program or something of that, like working with their coach and pulling them into so that they can be helpful and supporting the patient. You can always come up with contracts to say, if you're going to return to sport at your school, I need to make sure that you are doing X, Y, and Z so that you can be able to safely continue to engage. And a lot of times that actually does create a large buy-in for that. And then working really diligently on making sure that you're checking in before and after those forms of movement as you deem them to be safe for them to engage in, and normally reintroducing a different form of movement before their main one. If they used to be a runner, maybe they go out and try like swimming, or they go for a bike ride or something instead, so that we don't go back to the main one that was disordered for them first.
All right, perfect. Thank you for that. Any other last questions? I think we've hit all of them that have been put in the chat and in the question and answer.
I just saw Jade. Hi, Jade. She was saying that Jessica Setnick's RD Bootcamp is a good resource.
And actually, I believe this is Heidi, Jade's intern, that's joining us today. So, well, if nobody has any more questions, we're right at the hour. So that is all the time that we will have today. Thank you all again for joining us. Please be on the lookout for that follow-up email that will be sent to you, and it will have the link to your attendee dashboard which is where you will then have access to both the recording of this event, which I apologize, it started just a little bit late, so my introduction wasn't on there. This is one of my first times doing this, so I'm still learning all the ins and outs, but most of the presentation by Alison was recorded. So that will be on that attendee dashboard, as well as you will find where to complete that evaluation if you need a certificate and or more information about EDCare. We hope that you have a wonderful holiday season and a happy new year, and be on the lookout for more C events to come in 2022. Thank you all.
Thank you.